Good evening to those of you joining from Kenya. Again, my name is Ting Za. I am the Associate Director of UW Gain and pleased to introduce our speakers for our next virtual pediatric anesthesia didactics. This topic will be on pediatric blood and fluid management, presented by Dr. Eddy Mboya, who is a pediatric anesthesia fellow at University of Nairobi at Kenyatta National Hospital, and Dr. Priya Patel, a consultant pediatric anesthesiologist at the University of Washington and Seattle Children's Hospital. So thank you both for your time. Again, we will record the lecture and send it out a little later. And thank you all for joining. So I'll hand it over to Dr. Mboya.
Okay, thank you so much, Dr. Za. Hopefully I'm audible enough for everyone. All right, thank you. So as Dr. Za said, our topic today is on pediatric blood and fluid management. I know our audience, probably most of us are from anesthesia background and probably some from the critical care unit, but our talk is basically based on perioperative fluid management, how we handle fluid intra-op prior to surgery and probably post-operative care. I'll do the first half of the talk, then Dr. Priya will do the second half of the talk. In case there are any questions, sorry if I'm not audible enough, you are free to just alert me. Thank you. Okay, so that's the outline of our talk today. There'll be a brief introduction on this. We'll have some slides on physiology of body water, composition and distribution. We'll talk about some of the common intraoperative or crystalloids we use in pediatric surgery or pediatric anesthesia. Then how we handle fluids in the perioperative period. Then after that, we'll also have a brief talk on blood and how we handle blood perioperatively. So just an overview. Appropriate fluid management is vital in the perioperative period. Generally, this is to replace losses in patients who are hypovolemic or just as part of maintenance. And fluids generally in anesthesia or in children is also very vital for tissue perfusion. It can be detrimental either on the lower side or on the higher side. When we have dehydration, issues like nausea, hypotension, when there's hypovolemia, but then if you end up giving too much fluids, you also have issues like pulmonary edema that may occur. Of importance too, fluids can also be used to maintain the body's caloric requirements. That's glucose generally just to maintain ATP requirements for children who are not orally feeding. We don't have other options for giving probably enteral feeds or parenteral feeds. So that's some of the things I was talking about. Fluid therapy as maintenance, therapy during surgery, pre-op or post-op. You can use fluids to replace deficits which can come from fasting, evaporative loss intraoperatively, and also blood loss during surgery. Then we find that in some cases, we have what we call third space losses. These ones generally can never be quantified, but it's just movement of fluids between the different body compartments, probably the intravascular into the interstitial space. But we'll discuss about some of these things. So physiology of body water. So generally, we find that body water as a percentage varies with age and is inversely proportional to age. That means the younger a child is, or the smaller the child, the higher the body percentage of water. So we find that averages in a term fetus, okay, in a fetus, 80% of the body weight is comprises water. Full-term neonates, that's once they're born, 70% of the body it's water. At 1 year, this drops to around 60% of body weight. Then in adults, it varies between 50 to 60%. Then total body water is also further divided into other compartments. So we have the extracellular and the intracellular fluid compartment. And what we interact with most is the extracellular fluid, because that's what we probably test and that's what we're able to gauge its compartments whenever we test. And the extracellular fluid compartment makes like a third of total body water. So like what we've had, this image that we have projected over here, these giving us an approximate total body water of 30 kg child who is 9-year-old. At a percentage of approximately 60%, you find that this child's total body water comes to around 18 liters, and a third of it is extracellular fluid volume. The extracellular is further into two other compartments, that's plasma, which we find mostly intravascularly, then the interstitial fluid, which is now extravascular, and these are 3/4 of the extracellular fluid volume, which in this child is around 4.5 liters. And the interstitial fluid is basically the fluid that bathes cells, and it's also quite important because what surrounds the cells is quite important because through that you find glucose or other important components are able to move, or things like nutrients are able to move from the intracellular space into the extracellular space, and also removal of waste products from the cells occurs through this compartment, the interstitial fluid compartment. Then their composition also varies in terms of electrolytes. We have what are the major intracellular cations, and also you find that their composition varies. Like extracellularly, you find that the major cation is sodium, which makes around 135 millimoles per liter, which is almost like half of the osmolarity of your extracellular volume. While intracellularly, the major cation is potassium, but you have other things like magnesium, phosphates, and proteins, which make up that compartment. So it's good to know that. So whenever, what you always see commonly when we test is the components of the extracellular fluid compartments, which is mostly the plasma, how the plasma looks like whenever we do our lab test to see the components of this child's physiology or our patient's physiology. Then part of that volume, we have blood, and this also varies with the patient's age and weight, and is highest in the younger patients. That's from preterm, low birth weight patients. You find that the blood circulating blood volume is much higher compared to a term or an infant child. So at a child who's preterm, probably born before 40 weeks of age, your estimated blood volume will be around 100 mils per kg. So a child born at around 2 or 1.8 kgs, find that the circulating blood is around 180 mils. But when you have a full-term neonate, this ratio drops. But then as the child grows, it gradually drops up to around 70 mils per kg, which is almost as similar to what we see in adults. And the importance of this is that when a child is going through surgery or as losses that are actively ongoing, it gives you an idea on when to transfuse the child or how aggressive you should be with your resuscitation. Because you know that a preterm infant with just 200 mils of circulated blood volume, by the time probably they lose up to 30, 40 cc's of blood, that's quite significant. And you'll need to make a decision very early on how to manage that patient, whether you're still using your fluids or you're going to have to transfuse the child. And you find that that's different from an infant or a full-term neonate who's physically more stable and healthier than a preterm. Then just to talk about some of the fluids we use in theater or perioperatively. So we have crystalloids. These are quite common. Generally, crystalloids contain sterile water and electrolytes, and they come in different compositions and different osmolarities. So locally, what we use a lot is Ringer's lactate. Then we also have normal saline. Ringer's lactate is one of the things we refer to as a balanced salt solution, because its composition generally mimics what plasma is in a normal patient or in a normal child. So we have this image over here, or this table, which shows us the composition of different intravenous fluids that we use and their comparison to plasma. So you find that the first column, we have extracellular fluid volume, which represents plasma. The osmolarity is at 200 to 80, 300 milliosmoles per liter, which is normal. But when you look at saline, which is used quite commonly in our setup, you find that the osmolarity is at 308, which is a bit on the higher side. So in as much as saline or normal, saline is called normal, and it's also called isotonic, find that the higher electrolyte composition, it puts you at a risk of issues like hyperchloremic acidosis, because you find that in plasma, our chloride level is at just 103, yet saline has 154. If you give lots of saline without really monitoring your electrolytes, you are likely to get into an electrolyte imbalance. Lactated Ringer's or Ringer's lactate, or also what you call Atmans, which we use a lot in the pediatric population, though Dr. Priya and Za will tell us probably in their setup. But over here in our pediatric practice, we use a lot of Ringer's lactate. You find that its total osmolarity is at 273, with sodium making up a larger portion of that. That's at 130. But compared to plasma, it's a bit hypotonic. Then K is normal, potassium is normal, calcium levels are normal, but it lacks magnesium and ammonium. But then chloride and bicarbonate literally mimics plasma. So when handled well, Ringer's lactate or Atman's solution, basically, I wouldn't say would be the best, but it's one of those fluids that you can safely use in the perioperative setting. Then we have other things like half-strength saline, this is 0.45% sodium chloride. When you're worried about issues like hyperchloremic acidosis in the post-op setting, and you need to put a child on fluid maintenance, that's a fluid that you can opt for, because its composition is half the normal saline. Over here, we don't have plasma light, so I won't make a comment on that. Then there's 3% sodium chloride, which basically is used in management of hyponatremia. And it's the amount given is based on the level of hyponatremia that one would wish to correct. So in our practice, we also have what we call colloids. Used generally from different studies and people's practices. As we can say, it's controversial, really, but they have their advantages of crystalloids. Because if it's in probably a patient you're trying to resuscitate or you're trying to maintain volume, find that they rapidly expand the intravascular volume better than the crystalloids. And you'll probably use a smaller volume of the colloids in such a state because of the higher probably higher osmolarity and the osmotic pressure that it exerts intravascularly is way better than what crystalloids offer you. But generally, they have so many issues, and also one of the things is cost, why they are not easily used around. So one of the things, Constance raised some studies that I looked at. They were like post-operatively, when patients were followed up, there was probably a higher risk of sepsis, and no, when used in sepsis, there was a higher risk of renal failure. Then also they noted that there was a higher fall in the hemoglobin with colloids, increasing the need for transfusion. They generally have already made a comment on the cost. One of the colloids in practice, we have the gelatins. In Kenya here, we have what we call gelofusine. We have, then albumin is one of those. And the neonatal age, we use, albumins can be used during resuscitation, but the other thing is cost. Are we able to afford it? Because a child probably just needs 50 cc's, but albumin, or 20 cc's, but albumin comes in probably 100, 200 cc ampule. What do you do with the rest? So those are some of the issues that occur, but generally, what is advised is that to use a balanced salt solution. That's something like Ringer's lactate, but when you feel that you need to support further, then you transfuse blood. But there's a disclaimer. When transfusing, when you opt to transfuse, when a patient was previously on Ringer's lactate, you need to either change the giving set or the system that you're using for administering the blood, because the citrate, which is used for conserving the blood or keeping the blood coagulated, anticoagulated, will bind with calcium and cause precipitation with the intravascularly. So it's advised that if a patient was on Ringer's lactate, you either change your giving set or your Solisate system and start blood on a totally different system, or you have to flush that line completely before you give blood. Then now that we know the things that we can use for managing babies perioperatively, we need now to know how do we handle now fluids. So generally, prior to administration of anesthesia, these kids are always fasted for a certain duration. And the main reason that we fast is just to minimize the volume of gastric contents. That's reduce the risk of vomiting and aspiration. And the biggest challenge is aspiration that would worsen your perioperative morbidity and mortality because of the aspiration pneumonitis that may occur. Yeah, so I think most of us who are in anesthesia understand this. Nowadays, clear fluids guidelines tell us that up to 2 hours prior to onset or induction of anesthesia, you can give your clear fluids. Breast milk, it shows up to 4 hours. Infant formula and human milk, up to around 6 hours. Then solid or fatty fried foods, up to 8 hours. But generally, the practice is you need at least proper 6 hours for any solid food before you induce these patients. But then the European Society of Anesthesia had these guidelines that showed that even if you fasted these kids up to 1 hour with clear fluids prior to administration of anesthesia, the risk of vomiting or aspiration was really close to minimal. And one of the reasons why they felt that we need to minimize fasting period as much as possible, because issues that could arise, things like hypovolemia, hypoglycemia in children, that prolonged period of fasting would also predispose these kids to nausea and vomiting. Then there's just that anxiety, which most of us have seen. A child who's fasted, the one you're doing your surgery probably at 2 p.m. late in the afternoon, most of them always quite jittery, quite anxious, and always very tired. That may also worsen your perioperative morbidity. So that's why it's always advised that minimize your fasting guidelines, fasting period as much as possible. But in our setup, it's really, really difficult to do that once a child has been prepped for theater. And just to be clear fluids can be water, plain water, can be apple juice, can be just dextrose water, water with some dextrose, just to keep these kids, their glucose, to avoid things like hypoglycemia. And the quantity in the now perioperative setting, probably the child already came to theater, you needed to have studied the case, but there's a reason why there's a delay. At 3 mils per kg, if it's probably dextrose water, 3 mils per kg is generally adequate to be cleared within 1 to 2 hours prior to onset of anesthesia, so as to minimize the risk of aspiration. Other studies also showed that chewing of gum, as long as the gum is not swallowed by the patient or the child, there is no risk of aspiration. So you have to know that if a child was probably chewing gum, the best you need to note that that thing is out of the mouth, but that should not deter onset of anesthesia. Yeah, so I think just that. Then, okay. Prior to induction of anesthesia, generally the acceptance is a child who is sick or a child who is hypovolemic or dehydrated needs to be adequately resuscitated before induction of anesthesia, unless there are cases where the child's condition or the patient's conditions warrants you that surgery has to be done. Probably things like upper airway obstruction, which is now more emergent and would probably lead to the patient dying before the issues of risk of aspiration. Probably a child who has severe head injury, GCS is at 5, and despite having fed, you need to go in and relieve probably the intracranial pressure. Such scenarios, you have to go ahead with your surgery. But in cases where you may need to resuscitate the child, please, you sort out the fluid status, restore the child to normalcy prior to induction of anesthesia. And generally, it's agreed that volume replacements always start at around 10 to 20 mils per kg of IV crystalloids. This should be guided by the patient's clinical state. Over here, we call it, that's the bolus infusion that you need to give prior to even your induction of anesthesia. This helps us take care of the issues that result with probably the child that had fasted. There could be a bit hypovolemic, but not that significant. Then most of our anesthetics are vasodilators. The inhalationals are vasodilators. So you find that acute drop in your hemodynamics that occur as you're inducing a patient, that can be negated by this volume replacement that you give as a bolus. But this is also guided by the patient's clinical status, because you find that in like neonatal anesthesia, most of these kids already have a line running and maintenance fluids are ongoing. So this 10 to 20 mils per kg at induction may not be necessary at some point. But then as you're also giving this, it's good to be aware of your hematocrit level. Generally, at 21%, that's probably HB of around 7 grams per deciliter. By the time you need a higher volume of crystalloids just to restore a patient's volume, or when the hematocrit level is quite low, just to avoid further hemodilution, it's always just right to probably start blood as part of your maintenance therapy or part of your resuscitative therapy, so as to avoid other issues that will occur with the crystalloids. Then, as a guide, we have what we call the 4-2-1 rule. So 4-2-1 rule, I think a number of people have an idea what the 4-2-1 rule is. So generally, what 4-2-1 means is that the first 10 kgs volume is given at 4 mils per kg. The next 10 to 20 volume is given at 2 mils per kg. And after that, anything above 20 kg is given at 1 mil per kg. Of note is that this guideline was developed for kids who are healthy, who are not really undergoing surgery. This was just a maintenance guideline for patients probably who are sick in the ward and not able to take enterally, but not for intraoperative fluid management. But still, it's a good guide for intraoperative fluid management. So, because I already talked about the issue of bolus, which is at 10 to 20 mils per kg. So we have an example of a child who's 18 kgs. If we are to put this child on hourly maintenance, imagining we are not having any other extra losses, this child would probably be on something like 56 mils per hour. That comes about by the first 10 kgs of 18 is 10 by 4. That gives you 40. Then the next 8 kgs, you do that by 2 mils per kg, that's 16. You add that to the 40, you get 56 mils per hour. So if you don't have any losses, you don't have a blood loss, your things like you don't have like an open nose, this is not a child with burns, 56 mils per hour would probably be adequate. But you remember to look at the child, you have to individualize the patient's care. How is this child as you are deciding on this? If a child was already dehydrated, meaning you need to sort out the dehydration first before you work up your hourly maintenance. If there are ongoing losses, like a child is undergoing surgery, you find that there are cases where the evaporative loss is quite significant. Things like large abdominal, large laparotomies, some thoracotomies, you find that the losses are as high as 10 mils per kg. You need to consider this as part of your hourly maintenance. Another thing that somebody has to be looking at keenly every minute of every hour of your surgery is the blood loss. So there are multiple guidelines currently on how to replace blood volume, but I think part of Dr. Priya's talk will be on that. But if it's crystalloids that you have to consider your hourly maintenance. You have to consider the blood loss as you're computing your hourly maintenance of your crystalloids. But 4-2-1 rule is just a guide that you use to help you know that what amount of fluid would this child need. Yeah, but other issues like hemodynamics, because you might be sticking to 56 mils per hour, but this child is quite tachycardic. The blood pressure is on the lower side. That tells you that the 56 mils per hour may not actually be adequate. You may need to resuscitate the child more. But so I think those are some of the things that you need to look at. Then I think I'll just make a comment on use of dextrose. Our dextrose containing fluids intraoperatively. Not standard. Back in the day, in children, most people used to use dextrose containing fluids as part of their maintenance therapy. But intraoperatively, that's not really, I would say that's not really necessary, or that's not the standard practice. Though there are scenarios where you need dextrose, that's like in premature infants or infants who are less than 6 months, and probably they are not of the right weight. Patients who have failure to thrive, malnourished children, patients already critically ill, Patients who are previously on total parenteral nutrition or continuous enteral feeds, because their requirements are quite high. If you stop the enteral feeds for surgery, you'll need to replace those caloric requirements using dextrose. Then also patients with metabolic or mitochondrial disease. But the guide is every theater at least should have a glucometer, just for you to be able to check, to check what your random blood sugar is before you give dextrose. The other thing I'd wish to say that perioperative state is always a very stressful condition to any person, whether it's an adult or it's a child. And most studies showed that when you check your random blood sugar perioperative, that's post-op or even during surgery, you find that the sugar levels were a bit on the higher side. All these patients tended to have hyperglycemia, and this was able to maintain probably the intraoperative glucose levels because being a stressful state, find that there is increased release of cortisol, there's increased release of glucagon, there's increased release of adrenaline. All these tend to spike or give you hyperglycemia. So when you blindly give patients or children glucose-containing fluids without really checking, you end up now with hyperglycemia, which was totally unnecessary. And some of the issues that occur with hyperglycemia would be mostly post-operatively. Yeah, you'll have poor wound healing if it persists. You can have other metabolic issues that are related to the hyperglycemia. But that notwithstanding, if you need to give dextrose, you need to give, because hypo is worse than hyper, because one of the issues that may occur is neuroglycopenia in probably a small child. So surgery probably was not such a big deal. But then now, postoperatively, the child is weak, the child is quite lethargic, the child has altered level of consciousness because of a prolonged period of hypoglycemia, which probably impaired the brain. And if you can avoid, you'd rather just give dextrose. But the practice is check before giving dextrose. So probably, I think we already mentioned some of these things as Priya takes over. I think 421 as a guide, but individualized patient care. So you need to look at how is the patient's heart rate during surgery, capillary refill time, and though blood pressure should not be really used as a guide, because by the time your blood pressure drops, that's such a late signing, a late sign of hypovolemia, and you'll actually be resuscitating a child at that level. So you shouldn't wait for hypotension for you to know that you are probably you're in fluid deficit. So some of the things you need to have active bleeding, you need to look at your suction catheter, you must look at the gauzes that they are using. There's something called the pulse pressure variation. This is just a guide when a patient is under mechanical ventilation. That just tells you, will they be fluid responsive or not? But I think just that. Other cases which are longer and you probably fluid management may be a bit difficult, it's good to check on hot temperature gradient, need to monitor urine output. You can have other invasive techniques like invasive blood pressure, check on your systolic pressure variation, or even the central venous pressure. So I think from there, I'll allow Priya to continue unless there are any burning questions. Allow Dr. Priya to continue, then probably we'll handle all the questions at the end of the talk.
Hi, all. Can you hear me okay?
Yeah, I can get you.
Okay. So just a quick tidbit I wanted to say about the dextrose. I think you hit it perfectly, Eddy. I just wanted to add that sometimes we forget when kids have prolonged NPOs for things that are not in the operating room. For example, imaging tests like the MRI or other tests that might require a child to be NPO all day. It's good to be conscious of if there was a glucose check, especially for kids under 6 months, especially for kids under 6 months with cardiac disease. Often they're getting a lot of different imaging done, and you don't want the issues of hypoglycemia, and you don't want to have any brain damage. And there have been case reports of prolonged NPO times for cardiac kids where they have had issues with brain damage because hypoglycemia was not caught. So just something to keep in mind. Keep sharing your slides for me. Okay. And then I'm going to talk about blood loss and blood products and how to monitor them. And I'll kind of continue while Eddy gets the slides up. So monitoring blood loss during a surgery can be difficult. Often blood is in places that we can't see, whether it's in the abdomen, on the surgeon, on the floor, in the suction canister. So while you're using your vital signs to evaluate if your child is hypovolemic or having significant blood loss, it's really important to scan the room as well to evaluate for signs of blood loss. Sometimes it might be in the drape, so you might be unable to notice any blood loss. Sometimes surgeons aren't as forthcoming about blood loss, listening for signs of suctioning. Of course, certain cases you're going to be prepared for blood loss, like big intra-abdominal surgeries, but there are cases where unexpected blood loss occurs. So constant communication. There are definitely times when I've been like, has anything changed acutely? Are you pushing on something? We've had a big change in our hemodynamics. So constant communication can also help, along with using your monitors to guide when you have a slow, constant ooze during a case. Now, giving blood products can be good. You know, you don't want kids to get hemodiluted. You don't want them to be anemic. You need hemoglobin to carry oxygen to your vital organs. But you don't want to just transfuse arbitrarily and give blood to everyone. There are definitely pros and cons. You know, you're exposing your patient to antibodies. There's always a chance of a transfusion reaction. So determining when you need to give blood products and only giving it when necessary is key. Depending on the patient's age, you're going to have different hemoglobin or hematocrit goals. When you are a preterm infant or a term infant, your goals for your hemoglobin are going to be higher because your normal level of hemoglobin is expected to be higher when you're a newborn, you know, often greater than 14. Some newborns might even have as high as 17. As your age drops, the normal expected hemoglobin also drops, and that's because your fetal hemoglobin that you were born with is now getting processed, and your body hasn't necessarily ramped up the production of hemoglobin. So around 2 to 3 months, it's really normal to see a drop in hemoglobin. This is important because if you're preparing for a case and you notice your child's hemoglobin is 9 and you're like concerned, and like you remind yourself, oh no, they're 2 months of age, this is an expected drop, versus, oh, they're 6 months of age and they had a drop to 9 from 12 the week prior, then, you know, you might need to consider what is this drop coming from? Is it hemodilution from fluids? Is it an actual blood loss from a source that I need to be concerned about? So that's why I think it's important to know what your normal hemoglobin is based on age, to know if this is baseline anemia, blood loss anemia, or an expected anemia. And this can help guide if you're going to prepare for the case and have blood in the room or expect to transfuse, getting appropriate consents. And keeping in mind, like we talked about, the blood volume that a patient has is dependent on their age and weight. So standardly, we use our threshold to be, if your hemoglobin's around, 7 or less, then you need to think about transfusing. Now, this is acceptable for, a normal patient with no other comorbidities and standard size. So, generally a 12-year-old and above, or even a 6-year-old and above. But other comorbidities do require a higher transfusion threshold. For example, if you have congenital cardiac disease, often we do want the hemoglobin to be around 9 or 10. And this would be something that you would discuss with your surgeon about what your thresholds are going to be preoperatively, intraoperatively, and postoperatively. The reason being that they might have mixing of blood and their normal saturations might be 80%. And so you don't want to drop in hemoglobin or oxygen carriers, because then there'll be a drop in delivery of oxygen to your vital organs. Other exceptions to this hemoglobin goal of 7 would be patients who potentially have like sickle cell anemia. They are prone to undergoing crises. You don't want more vaso-occlusive events for them. You don't want more pain for them. Patients that are premature often have higher thresholds as well because they're at risk for apneas. They may have higher oxygen requirements. They also may have pulmonary disease. And so they may have two reasons to need higher hemoglobin thresholds. And that's because they may have poor diffusion of oxygen because of their bronchopulmonary dysplasia, or they may already be on oxygen. So you need to assist them in other ways as well to deliver their oxygen. Now, when we're in a surgery, sometimes it can be hard to know, like, okay, at what point should I get worried? In an adult, if you lose 1 to 500 milliliters of blood, it's really not a big deal. Most adults can tolerate that very well. But when you're younger, 100 cc's of blood loss in a 2-year-old is a decent amount. So we often use the allowable blood loss equation. And this isn't a hard, fast rule. It's something to help guide you into, okay, once we lose this much, or once we get halfway to this volume, I need to start being concerned. Do I have a type-in screen? Is there blood available? If there's not, how long will it take to get the blood? So for example, if you had a 14-kilo kid, the way we use the equation is allowable blood loss is the estimated blood volume of the child. So 14-kilo kid will be about 1.5 liters. And you would do your starting hemoglobin and you would minus the acceptable hemoglobin. So say we said that was 8, and you divide that by the starting hemoglobin. So it's a kind of ratio. You can use hemoglobin or hematocrit. I apologize, I made an error here. It should be the same. If you use hemoglobin, you should use hemoglobin values through the whole equation. If you use hematocrit, you should be hematocrit values through the whole equation. My apologies. So for this kid who's 14 kilos, and if our acceptable end hemoglobin is 8, then the allowable blood loss is 350. So once you're getting to 200, 250, and if you think there's still going to be more blood loss, then you need to consider what your next steps will be. Now, if you're unable to give blood for whatever reason that might be, maybe you actually haven't hit the allowable blood loss volume. Maybe it's only 200 and you're like, okay, we're going to avoid a transfusion in this kid because of other reasons. Maybe you're concerned about exposing him to other antibodies. Then when you resuscitate with crystalloid, our general rule of thumb is double. For example, if he lost 200 of blood, then you want to resuscitate with about 400 of crystalloid. Being aware that, you are at risk for getting into volume overloaded states or risk of pulmonary edema, depending on how significant the blood loss is, maybe you wouldn't extubate postoperatively to optimize pulmonary status. But that is a general rule of thumb. So kind of resuscitating blood with double the amount of crystalloid if you're not going to give blood. So remember, your goals in transfusion are a hemoglobin of about 7 to 8. Of course, there are exceptions. You want to minimize dilutional coagulopathy, because if you're having blood loss, you want to make sure that the patient can clot to avoid further blood loss from the surgical site. So after giving about 2 volumes of resuscitation, so in adult, maybe 2 units of blood, you might want to consider giving other things like factors, FFP or plasma, because then you want to ensure that you have the other components of your blood that will lead to clot formation. And then you, of course, want to optimize hemodynamic stability and optimize oxygen delivery. So here are the different type of blood products that we give. Generally, a starting bolus is somewhere around 10, 15 to 20 cc's per kilo. Once you reach a weight of about 30 kilos, 10 per kilo is 300, which is about the volume of a blood unit. So it would be fair to just give 1 unit. But once you're under 30 kilos, you need to think about, okay, if it's a 10-kilo kid, 10 per kilo is 100, 20 per kilo is 200. So that's less than 1 unit of blood. And the same numbers can be applied to platelets, FFP, cryo is a little bit less. And then not everyone has fibrinogen separately, but something to consider. So for every 2 units of blood you give, or 2 boluses, I would consider the FFP. It doesn't mean you have to give it, but give it a thought. Are you concerned about a coagulation issue? Is the surgeon complaining about oozing from everywhere? Should you consider giving it? If able, should you send some labs to see values and clot timing, if that's even possible? A couple things to note when you're giving blood. Eddy already hit on this, but you want to make sure that you're not mixing it with LR. The citrate's already going to bind up that calcium, and you're already at risk for hypocalcemia. You don't want more issues related to that. The other thing is we try to give blood through a warmer, because blood is cold and you already going to likely have a hypothermic patient. That easily happens in the operating room. Hypothermia is also associated with causing coagulopathies, so we don't want to make that worse. So if able, giving it through a blood warmer. Now, common side effects of transfusions. These are like the common ones that are not so terrible but need to be managed. And on the next slide, I'll talk about the more scary ones. So hypocalcemia, and that's because of the citrate that's added to blood. Blood contains citrate, mannitol, glucose, and adenine, and this is to help with its storage. So the citrate helps to avoid clotting of the blood, and so that's going to bind up your calcium. So often we say for every 20 mils per kilo of blood that is given, you need to give supplemental calcium. Often you want to give it on a separate line or flush that tubing of blood and then give calcium. So you don't want to give it with the blood, you want to give it separately. There are two different forms of calcium that are generally available, calcium gluconate and calcium chloride. We tend to give calcium gluconate peripherally, and calcium chloride we prefer to give centrally. You'll get more bang for your buck with the calcium chloride, meaning a bigger bump in your calcium level, but peripherally it can be irritating to the vasculature. So be cautious if you give calcium chloride peripherally. The general bolus dose would be 20 mg per kilogram, and I would give that in divided doses. So for example, if you had a 10-kilo kid, 20 mg per kg would be 200 milligrams, and I would give it in 50 milligram increments, every 2 minutes or so. When you give it, you'll see an increase in your blood pressure because it's going to improve contractility of your heart and your vasculature. So it's going to help to increase that tone if you're facing hypotension. Other things that can occur is hyperkalemia. That's due to breakdown of your cellular components in the blood, and intracellularly, as we know, the concentration of potassium is higher. So older blood is more likely to be associated with higher levels of potassium being exposed to the patient, and it's something you should just monitor. So after every 1 or 2 transfusions, running a lab, watching your EKG, it's rare now to see severe hyperkalemia due to transfusions because the way blood is stored is pretty safe and it's been pretty optimized, but I think it's still something you should be watching for, especially in patients who maybe don't process potassium the same way or who are already high. So your kidney failure patients who are already running high on their potassium. And then the other common thing is fever. Sometimes the fever is just not related to, say, a hemolytic transfusion reaction. It's just a fever related to blood components, and the patient always gets it. And some of these kids just need pre-treatment with Benadryl and or Tylenol. Now, if you're concerned about some other reaction, then you need to stop it. But if it's just a fever as expected, especially happens in patients who receive blood transfusions regularly, maybe sickle cell patients or cancer patients, often they get pre-treated before they get blood products. Next, we're going to talk about acute transfusion reaction. So it could be as mild as just an allergic reaction. Mild allergic reactions might just show up with fever and a little bit of itching, and that might be something you guys are okay with because you're not thinking it's an anaphylactic reaction. If you suspect an anaphylactic reaction where you're not only having just fever and itching, you're having respiratory issues, rash, stop the blood product immediately and make sure you're assessing your patient and stabilizing them. Now, this can be hard during anesthesia because we're not really looking at the patient. We're just treating to improve our hemodynamics. So if you have something weird happening, don't hesitate to look and see if your ventilation has changed. Do you have increased peak pressures? Listen to your child, and also look at their chest if you're able to. That way you can catch any type of rash that would be occurring. Other type of reactions that occur are hemolytic transfusion reactions. These can occur within 4 hours. Or even 24 hours. If it's a hemolytic transfusion reaction, you might have flank pain, you might have DIC, so signs of bleeding, hypercoagulopathies, hematuria, hypotension. So something to watch for really closely. You might not experience it in the operating room. It might happen later. The other type of reactions that can occur that can be pretty detrimental to a patient's life are TACO and trolley. So the first one, TACO, which is related to transfusion-associated circulatory overload. That is usually occurring within 6 hours of your transfusion. You're going to have tachycardia, dyspnea, wide pulse pressure variation. You may even have elevated BNP. You have a risk for volume overload. And often for those, you're treating with diuretics versus TRALI, which is a transfusion-related acute lung injury. This is when you have bilateral non-cardiogenic pulmonary edema. So this is the diagnosis that occurs when you've occluded all other reasons for your pulmonary edema. And you're going to have hypotension, dyspnea. This is not treated with diuretics. This is just treated with supportive care. And this is because of an interaction between the leukocytes of the recipient and the antibodies of the donor. And this can be pretty detrimental to the patient and hard to treat and sometimes hard to diagnose because there might be multiple reasons for you to be having trouble ventilating this patient. And then the other two reactions that can occur, now this is not all encompassing, but these are kind of the most common things you might see. Delayed hemolytic reactions. These can occur days after, even up to 10 days after. And in these reactions, you might see jaundice, you might see anemia, and that's because of that cell breakdown. The reason you might suspect this is because you might see the jaundice or you might see an anemia when your patient was previously stable. And the way you might be able to tell is by doing an antibody screen for the patient, and you would notice that there are new antibodies in their blood that were not there before. And the last one I'll mention is graft versus host disease. This is fatal in some patients, and it can be avoided by giving irradiated blood, which is not always possible everywhere. There are certain patients who should get irradiated blood when possible. Those patients would be immunodeficiency patients, so patients with like severe combined immunodeficiency, or those on immunosuppressants, like patients who have had transplants or cancer patients. Sometimes premature infants are also given irradiated blood to minimize any type of transfusion reactions. By giving irradiated blood, you're kind of washing it out of all those other components that could cause a reaction. Now, in the perioperative period, it can be hard to assess fluid states. You know, you assume if your patient's been NPO for a certain amount of time that they're going to be hypervolemic and you're going to need to treat them. Here are some ways that you can kind of assess, because it's very hard to assess intravascular status. You know, subtle things, if they're just mildly dehydrated, might be, you know, drop in body weight, maybe they have a flat fontanelle. If they're moderately dehydrated, they might be more irritable, maybe they have dry mouth, slightly tachycardic. And if they're severely dehydrated, you're going to see the more scary things like lethargy, sunken fontanelles. And remember, hypotension's late. That means you need to catch up real soon. A couple of things to consider in the perioperative period that you might see them, and just kind of touch on different things that happen because of fluids, would be septic shock. This can happen because you're acutely ill due to an infection. Postoperatively after surgery, you can develop septic shock. So this is a concern for you, because if you're taking care of a patient in the surgery or after the surgery that has septic shock, you need to make sure you're resuscitating them. You need to make sure they're on antibiotics. You need to consider pressors early. You want to maintain end organ perfusion, and you want to make sure you're finding the source and treating the source. Other things that can occur are fluid overloading. We're talking about given fluids, all types of fluids, and sometimes we can go a little overboard because it is very hard to assess. And sometimes in the surgery, they might need a lot of fluids. And then in the ICU, all those fluids move into the third space, and then they'll have to redistribute back into the intravascular space and then be excreted, you know, peed out, given diuretics. And so this is something to constantly be watching. The fluid states shift a lot in the perioperative period. Sometimes they're intravascular, sometimes they go extravascular. Sometimes you need to help them come back intravascular. So that's where you need to be looking for edema, listening to the lungs, watching for tachycardia, doing labs, considering diuresis. Then, as Eddy touched on earlier, if you give too much fluid, especially saline, you can have hyponatremia. When you undergo surgery, you often release ADH, and so that's why urine output can decrease, and that's because your body's in a stressful state, so it's trying to hold on to everything. And so that can also result in increased fluid in the intravascular space, resulting in a hyponatremia. So it's important to know why it's occurring and what you can do to treat it, because you don't always want to just resuscitate with hypertonic saline. Sometimes slow diuretic therapy might be what you want, sometimes slow correction with just a little bit of sodium supplementation, or watching for a day, because if you correct too quickly, then you can also cause problems. Specifically, you can cause encephalopathy, cerebral edema. So you want to watch which way you're going and how quickly you're shifting your sodium. Always treat slowly, whichever way you're trying to move that sodium. And then a couple things about postoperative management. In kids, if they're able to take PO, we encourage PO. PO is the best for them. They can guide how they want to take their fluids, how thirsty they are versus over resuscitating them. Now, if a kid is under 6 and they're going to be NPO for a bit, I would consider running dextrose fluids as part of your maintenance therapy. When I say a little bit, I mean like overnight, the next day. If it's just 2 or 3 hours, consider letting them have some PO. A lot of times here, we would consider D5 half normal, but make adjustments based on what the patient's electrolytes are or what your concerns are. And you want to always be evaluating your electrolytes, especially in sick patients, especially in patients who have been on fluids for a long time, or on patients who've received a lot of fluids. So essentially, always reevaluating, personalizing the goals for the patient and the current state, and then discussing as a team what the goals are. Because based on the surgery and the patient's comorbidities, for example, cardiac patients, you might have higher hemoglobin thresholds. Or maybe if it's a cancer patient, you're trying to decrease the exposure to further antibodies. So just always discussing as a team what your goals are and reassessing, and not being afraid to ask others for advice too, because assessing fluid state is not easy, and it's something we're always having to reassess and reassess. Anybody have any questions?